So, good evening, everyone, and namaste, and welcome to our third week of discussion on WHO's medication without harm. And we agreed to discuss the three focus areas as mentioned in the WHO document. So, we finished with high risk medications, and we are going to discuss today transitions of care, medication safety, transitions of care. And next week, we are going to discuss polypharmacy, and last in this, going to be safe medication administration practices for nurses. Now we are going to end our endeavor to share and learn together with all nurses and students. And thank you so much for so many of you being here. What time we already have 90 plus people. Thank you very much. That gives a lot of encouragement and hope to see we all care for patient safety. Thank you once again. And so we just pull up the presentation and we start. Okay. So pursuit of patient safety. And this is our tagline that every year we do some activities for people, for educating, encouraging nurses to be safer around patients. So today, as we discussed, we are going to discuss about medication safety in transitions of care. And I'm very sure that there are some images coming to your mind when I say transition here. So we are going to discuss today. We will give a brief intro about what exactly is transitions of care, and then we talk about the frequent transitions of care, medication reconciliation and medication review, and why consider medication safety in transitions of care, what has been done to improve medication safety, what needs to be done, and role of nurses in transitions of care and medication safety. Uh, all the content, barring one or two slides, they all are taken from the technical report that you see here from the WHO's website, Medication Safety Without Harm. So they have released technical report on the this domains. So anybody can go and access as well. So let's get into discussing what we are today. So before that, I just thought we will look at a small, very short video where Dr. Eileen Haley is explaining about what is transitions of care.
Transitions of care, in the traditional sense, is when a patient moves from the inpatient acute stay to home or to a skilled nursing facility. You can also translate transitions of care a little bit more loosely. Transitions of care can be when a patient transitions from an intensive care unit to a med-surg bed. That requires a level of expertise and an understanding of evidence around the person's medical complexity to be able to transition from one level to another. It's an emerging field that's hugely needed in hospitals and in ambulatory and in community settings. Understanding the medical trajectory and the physical and social determinants of health is very important, and nurses really stand at the helm of that. Physicians and hospitals are inundated, and having nurses possess this skill set will not only benefit from a financial standpoint the institutions, but also, most importantly, patient outcomes and the health of the population.
Okay, friends, we have set the tone to understand what are transitions of care. So when I hear the word as a nurse, I think of patient movement from one hospital to another, inside the hospital, from one ward to the other ward, or from OT to ICU, ICU to OT, and patient coming to hospital from home, and then patient going back home. So any movement, I can imagine they all will fall into transitions. The WHO document very particularly discusses about a few transitions of care. I'm going to focus on that only from the document, and then we will talk about the, like the video told, what are the interpretations of transitions of care, where I think nurses have a much larger role to play. So, what transitions of care? The various points where a patient moves to or return. So if a patient goes to CT scan and then comes back, that is also trans. So I know that all the hospitals are going for accreditation. There is a protocol that for transfer in and out, what to do when the patients are shifted to for testing purpose, what you are supposed to do. Many hospitals have their own protocols, right? A particular physical location. May I request everyone to stay themselves muted, please, because you will disturb the session. So anywhere a particular physical location or makes contact with the healthcare professionals, going to a clinic and then the patient goes back after receiving healthcare, even that becomes transitions of care. So in the document, the WHO document very clearly depicts the patient's journey across different transitions. So let's say this is the primary care journey where patient is receiving care where they are, maybe their GP, local hospital. So there also when they reach a private practitioner or the GP, there is also medication that is being given. So there is prescribing, and maybe there is transcribing, dispensing, administering, monitoring. So this the patient may be doing at home. So when they have any problem, then they may get admitted to the hospital. And there is something called the pre-medication, pre-admission medication list, and we are very much aware of that. When patients are admitted to the hospital, we do take a medication history. What medications are the patients on? So that we are aware of, but we will know very soon that despite knowing all this, there is a heavy burden, potential harm and errors at these points. Then in the secondary care journey, same medication things are happening, prescription, transcribing, or please keep yourself muted. Then the dispensing, administering, monitoring, the same process is happening in the hospital as well. So medication is prescribed on admission. Inpatient medication changes are happening, and the patient goes home. So then there is a communication that is happening at the time of discharge. So this is pretty much the medication journey of a patient. Okay, I agree with that. Now this is a nice picture where it is again from the same document where they talk about at home, and this is very relevant to most of us because most of us we work in hospital setting, not in a primary care or in a small nursing home. All of you are sitting here, or they are all, you're all students who are wanting to work in hospital, wherever. So patient at home, patient comes to hospital, so they get admitted, and then we are taking a medication history, right? We all take that. Now, this is very important how you take the medication history. Then, verifying medication history using reliable source of medication information. We'll come to these points in detail in a while. So, actually, you can see the person has taken history, probably they are comparing. And then, what happens? Doing a medication reconciliation at the time of admission. Okay, we will know what is reconciliation in a short while. So at the time of admission, you are taking the history and you are reconciling, and then the patient is staying in the hospital, whatever day, 1 day, 2 day, or 5 days, 10 days, it doesn't matter. So during the days, maybe some medications are being added, some are being removed. So it keeps on happening, and then the patient finally getting discharged. He's getting discharged, and that time also there is a reconciliation happening. So pre-discharge we are teaching the patient what to do medications at home. So we are pre-discharge communication and patient engagement is happening. and then the patient is sent home, right? And we are hoping this patient should not come back, he should be well, but we know that some of them come back. And the reasons can be many. One of the reasons can be not understand their medication regime, what to take care and what to do. There is a possibility that's how they come back. The burden of harm and errors is also discussed in the document, which we will be discussing in a while. So, frequent transitions of care, as described in the document, are when patients are admitted to the hospital, to a community setting or a primary care, or where a medication history is being taken. So, what WHO insists whenever a patient gets in touch with healthcare provider, medication or medication history has to be taken. Then an inpatient prescription will get commenced. Then medications are just started or changed or discontinued. Those of you attended last week's session, you would remember the story of the 75-year-old lady who was given Bovaran when she had pain, and then there was, she had taric, but somehow the doctor failed to write it in the prescription, and the lady forgot, and she continued to take, got into major trouble. So it can happen with any patient. So while we'll be sharing some more case studies like that with you. So the other transitions of care is transfer from one area within the hospital to another, particularly when separate paper or electronic medical records are kept. For example, emergency department to ICU, operating theater to clinical ward. So this is what is in the document. But for patient safety sake, I would say any kind of transfer from one area to the other, even a patient going from inpatient to a CT scan, that there is transition of care because sometimes the medications can be administered in the CT scan. So they would need to know the medication history, especially the allergy. Last time we discussed about checking the allergy status of the patient. And next one is referral from primary care to secondary or tertiary care. So there is referral that is happening from primary care to secondary care, tertiary care, or they are going back from the hospital back to the primary care, or they are going home. So they get some instructions. Transfer from one hospital to the other, or a long care facility, or a nursing home, or a rehabilitation facility. So all of them are transitions of care. This document very clearly says that transitions of care do not include care handover and handoff during staff transition. That means shift handovers are not part of the transitions of care, but loosely put, we can understand that even when you hand over the patient from one shift to the other, your hand is raised. Do you have a challenge or a question? Is the the presentation, the phones are all clear to everyone? Lindsay, can you come to me, please?
Sorry, ma'am?
Yeah, is the slide is clear?
Yes, yes, the slide is clear, ma'am. Your sound is also audible.
Because I just saw Sunita's hand going up. She has a challenge or something. Okay, so no worries. So let's continue. So now we come to, so we understand what is transitions of, what does the WHO say? So as nurses, I would only advise that just think of patients moving from one place to another, wherever they are. And in the hospital, when we hand over, there is a transition happening. So by definition, that does not come into the purview, but we we'll have to think that way, because we know that shift handover is one of the root causes of many missed care and errors that happen in the care of the patient. Medication reconciliation is a formal process. Now, it's very important to know that this is a formal process in which healthcare professionals partner. These words are very, very important to know, that this is not because accreditation is asking, it's a formal process where healthcare professionals are partnering with patients to ensure accurate and complete medication information transfer at interfaces of care. So there is always patients and caregivers involved in the process. Now, this cannot be done in a jiffy. Patient came and say, "Oh, are you taking any medications?" And you say, "Okay." Patient said no, but you need to ask some more questions. Are you taking any supplements? Are you taking any herbal medications? It is very important to note that. Maybe many nurses will say it is doctor's responsibility. Agreed. Doctor will also have to take. And nurses also, we know that we are trained to take complete history of the patient. That's the only way we will know our patients much better. So at each transition of care, we have to ensure the medications are reconciled. So let's say a patient gets admitted to the hospital and he's taking maybe 10 medications. Okay, you have to capture all the medications into the medication record. Suppose that when the patient after got admitted, maybe the doctor discontinued one medication and then maybe he added another more. So every time when you are transitioning the next set of person, doctor, nurse, or whoever it is, they have to know that what is the medication reconciliation from the time that he came to hospital, what has been stopped, what has been added, what has been held. So that reconciliation needs to happen at every transition of care. And I'm very sure that the nurses who are working in hospital, who are daily doing patient handover, you do look at the medication chart, right? And you tell the next person, this is what is happening now. Medication reconciliation means that you have to start quickly telling the story from the beginning till now. That's how you are reconciling every time, that everything is okay, we have not missed something, we have not added something that could, harm the patient. The best possible medication history, this is called BPMH. This is an abbreviation given in the document. This is called BPMH. The best possible medication may differ from what was prescribed or dispensed. So now, please remember is that if patient gives you a patient gives you a paper saying that this is my medication, you need to ask, can you confirm to me whether you are on all these medications in the same dosage? I'll give you an example. My mother is 84 years, so she gets consultation every 3 to 4 months. So last time the prescription was given, and post that she had some change in her blood pressure, so the doctor stopped the beta blocker. So I noted it, and I have educated my mother. I removed the medicine from her medicine, and then later her BP was still not going up much, so he again stopped Telma. So that is also removed. So two medications have been removed, but her prescription has not changed. So if my mother goes to that doctor and information is not given to the doctor, doctor, verbally you told me to stop this and to stop this, there is a possibility that that medication will still remain in the prescription. So that is why the best possible medication history, whether it is a doctor or a nurse, you need to ask that this prescription, are you taking all these medications, has there been any change? That's the simple way of telling the best possible medication. And please understand, this can never be completed without having a communication with the patient or the patient's caregiver. So please remember the best possible medication. At the next transition, the updated medication list changes made to the BPMH should be communicated to the patient and future healthcare providers. If the patient is coming from ER to ICU, that people have done the reconciliation, they have to tell this is what has been done. And suppose ER did not have time to do the BPMH because there is emergency happening, there has to be a process in the hospital to say the BPMH will be obtained ICU. It is very important. ICU ward, wherever the patient is admitted. So I think this word, personally, I feel this word should now appear in the policies and protocols of the hospital to educate, because I know that you all are getting educated, but the same thing needs to be communicated to the medical professionals as well, because they also should be knowing about it. What changes are happening, what is the focus of WHO is focusing on countries that you need to initiate. Now, I don't know how many of you know that our government of India has started this digital medical record called Abha, which is connected to the Arogya Setu. So you can actually upload all your medical, reports and history. But for that, the hospitals also need to become partner, and the patients also can. So I can have an Abha number, but if I'm going to a hospital, unless that hospital is on the platform, the prescription will not come. So our country is also doing something about medication reconciliation, but it will take time for everyone to come on the same platform. So there is a whole lot of goodness that we can offer to our patients, and we can make it far more safer for our patients. So at the next transition, updated medication list. This medication reconciliation word has been around for very long time. I have known about this terminology way back in 2008, and we also initiated a medication reconciliation process when I was heading Fortis Vasant Kunj many years. And I am very proud to say this was initiated by nurses, and the nursing department was kind of maintaining it. And slowly the doctor said this is a very good idea. So they started looking at that list. And this we initiated because we had a couple of real incidents where some medication was, held for some time. They forgot to start it when the patient went home. Then after a couple of weeks, the patient came back because the patient did not take his medication. So something very not positive happened, and they had to come back to the hospital. Or sometimes you have left a medicine there in the list which the patient should not have, because sometimes doctors say, oh, give all the medicine that he's getting the last day in the hospital. Maybe some of the medication they should not be given to the patient. It could be harmful. So all this watching like a hawk on the patient safety can be done by a nurse. But if we start asking, this is not my job, then there is a challenge. That's what I would say, that we all are educated for 3 years and 4 years. Why can't we get involved in this process? Though, the document will not talk very clearly that it is only the doctors or only the nurses. They talk about the doctor, nurse, pharmacist, patients, and families. All of them need to be involved in that, right? So coming again, talking about medication reconciliation process. So they talk about three very important segments. The first one is building the BPMH. I'm sure that you understand BPMH by now. Best possible medication history. Reconciling the BPMH with prescribed medicine. So what happens? You take a medication history, you have a list of it, and then when you order, you are reconciling. No, have I missed any medication? Did I add something that should not have been given? So you reconcile, and every transition, the communication is being given very diligently and very carefully. So please understand, BPMH is a systematic process of interviewing the patient. All these sentences are from the document. You can always go back and in. So interviewing the patient, family, and caregiver. So you need to look at your own interviewing process. And of course, the doctors also, when they take history, do they spend enough time to understand the patient? So they talk about interviewing the patient and verifying the history with at least one other reliable source of information. So when you ask the patient, that's one. Second is maybe they have a paper, they have a prescription, or they have a photo in the mobiles, or they have brought the medicines. So that is your reliable source. So when I was in the hospital, I used to teach my nurses, I used to tell the patients also, the best way is bring all the medications to the doctor. Whatever that you are taking, you bring it to the, consulting room and say that I'm taking this one once a day, twice a day. Maybe that's the best way you can get the actual medication. I know the hospital protocol will say patients should not, take self-medicate and they should not bring medication from home, which is fine. But you can always look at the medicine to take the best possible medication history, correct? So please keep your videos also off. So somebody is, having their on. Okay, thank you. The reconciling the BPMH with prescribed medication. That is your second step. So BPMH is every time compared with the comparison is happening every transition of care. At every transition of care, if the comparison is being done and it is available for the caregivers to match, then you can avoid discrepancy.
Ma'am, excuse me, ma'am.
Yes, please.
Ma'am, the screen is not clear actually. It's showing us something black in between.
1 second. Is that clear?
No, ma'am. Yes, ma'am.
Is it clear? Is it clear?
It's on the corner, ma'am, on the right side actually. Now it's clear, ma'am.
Okay.
Now it's
Okay.
clear. Thank you, ma'am.
Thank you. Thank you for that feedback. All right. So reconciling the BPMH with prescribed medication, as I mentioned, every time you are comparing, and when you compare, you can identify discrepancy and you can resolve them before it can harm the patient. So why are we taking all this pain? So because we want to prevent any harm. Now, why we are talking about medication reconciliation, there is enough research evidence available that, is a junction at which, things can go wrong, people can overlook and patient can be harmed. Then communication of accurate medication information. Communicating accurate medication information. Now, I would like you, all of you, all the nurses and students, please keep that here in your head. Communicating accurate medication information. So when we come to role of nurses, we need to think about this. What does this sentence us? Apart from whatever is written in the WHO document, I always talk about the individual nurse's accountability. I would like to emphasize on that. This is very, very important. As an individual nurse, do I care for my patient's safety? In that case, probably all of this makes a lot of difference to me. And when I'm listening, I'm probably thinking, what can I do in my practice? So, communicating accurate medical information of the list of current medication and reasons for changes. Previous list is provided to the patient. So, when you are educating the patient, also you are telling, okay, your this medication has come because of this, and this is the medication added. Please remember that this medication needs to be, held for so many days. And my personal experience of being a bedside nurse is that every time you involve a patient, they are becoming your watchdog. They will tell you in case you are having an oversight, because no one knows the best about his or her medication. The only constant in this entire, story is the patient, because the nurses change, the doctors change, caregiver change, hospital change, everybody changes, but patient remains the same unless and until that patient is unconscious. But rest all the time, the patient is the constant and they can communicate and tell us what needs. So in case patient cannot be involved, then you have to involve the family or the caregiver or the significant other, whatever you call them. So they need to be involved. That's a high point in this entire document. Now, the document talks about, we are trying to prevent medication discrepancy when we are doing medication reconciliation. Now, what is medication discrepancy as listed in the document? Any difference between the medication use history, admission medication orders. So, if the patient was taking XYZ, have you continued with the XYZ or you dropped something? And if that discrepancy, it is intentional or it is intentional or undocumented intentional or unintentional discrepancy. So all these kind of errors can happen or discrepancies can happen. So what are intentional discrepancy? These are the result of conscious decision making by a patient or a healthcare professional. The doctor decides that this medicine need not be given because the patient's diagnosis or whatever it is. So that is a intentional discrepancy. Now, undocumented intentional discrepancies are a failure to document a conscious decision. So maybe the doctor wanted to stop something and or wanted to give some other version or reduce the dosage of a medication. The intention was there, but then they failed to write it down. They did not document. So that is a undocumented intentional discrepancy. Doctor knew I have to make the change, but somehow it was not documented. That is unintentional, intentional. Now coming to the unintentional discrepancies occur when there was no conscious decision made. Here, what happens? The BPMH was not taken seriously. So, when the patient got admitted, we just took some history and then we moved ahead and we just started treating the diagnosis. So this can be a phenomenon that can happen in any hospital, because I have been a recipient of care. My family has been recipient of care, and I can tell you that many times I used to think that if I was not the attendant, what would have happened? Because many a times I reminded the doctor, my father has renal failure. Do you think that he needs to have this medication? Is this dose correct? That's the time. Oh, thank you for, reminding me. So now it's kind of, that means you're not aware of it, that you have to do that. So there are unintentional discrepancies and undocumented discrepancies, and unintentional discrepancies can result in medication errors. No, and that can lead to harm. Now, for example, CRF patient, you find that's a borderline potassium, and if you don't know the patient has got renal impairment, the doctor may order for potassium syrup to take it home, and the patient is not aware, he will take, and after that they will end up with, arrhythmia and emergency because of hyperkalemia. So all these things, can happen when we are not taking the history and when we are not doing the reconciliation. Now, unintentional discrepancies, they can fall into two categories. One is omission. We know the word omission. For example, not prescribing a required medication. That means patient needed something, but you did not write, so that is a omission. What is commission? Commission is that it is like you are doing something that should not have been done. That means lack of patient adherence. So patient, when he goes home, he did not take the medicine. That is a commission, that knowingly they take the medicine. Wrong dose and frequency, wrong medication, failure to communicate, all of them becomes commission. That can involve a doctor, a prescriber, nurse has failed to communicate. All these things can happen. So this medication discrepancy is what we are trying to avoid by doing medication reconciliation. So then there is another terminology that is used here, medication review. When I was reading this particular, definition, I went back all the way to my ICU, and we had great intensivists to work with. Medication review is a structured evaluation of patients' medicines with the aim of optimizing the medicine use and improving the health outcome. This entails detecting drug related problems and recommending interventions. So, every day in our ICU, before the round, we will make sure whatever x-rays are done, all the films are available, all the lab tests are available, all our output chart is all updated. The nurses have all the medication chart ready, and when the rounds happen, medication review is definitely a very important part of the discussion. So the consultant will definitely say, let's go to the medication. So the resident will be actually reading, he's on this, and he'll say, okay, just stop. All right, what did you say that his renal function is? Okay, maybe we need to adjust this medication. So there is a discussion. There is a full medication review happening on every round. That itself is an opportunity for medication reconciliation. Now, can nurse participate in that? I would say 100 percentage, because nurses know the patients even better than doctors many a times. You just need the courage to speak up to say,
थोड़ी
doctor,
देर लेट आप एक बार उनसे बात करें.
nephritis drug. Would you really want to continue with that because his BUN creatinine is like this, or maybe patient has a liver failure, some impairment. So you would like to warn the doctors. Maybe some drug interaction is happening. Maybe the doctor is saying, okay, let's increase the warfarin, and you say, sir, sorry, sir, yesterday's PT-INR is this. You say, okay, let's look at it tomorrow. So maybe you are the watchdog. You are going to tell the doctor, this is what, just gently you can always remind them. So once medication reconciliation has been performed, then there has to be medication review. I mean, in a hospital, I would always say that during rounds, there must be a medication review to say in the ICUs and all, it goes without saying. Every day there are changes in medication, so medication review has to happen, and then future treatment. And before discharge, also very important to do a medication review. So, medication reconciliation includes a thorough review of medication at each important point. And during a comprehensive medication review, the prescriber is supposed to think about the risk and benefits of each treatment and then discuss it with the patient, and decisions are made about future therapy. And I'm very sure that people who are in working in oncology, you are used, right? The doctor will talk about the chemo drugs which are going to be given and what are the side effects that can be expected. They will explain the duration, the cost, and then the family or the patient, they takes the call that what they need to, undergo. So I know that in that specialty there is definitely a lot of discussion happening, and this may also occur at or after transition of care. That means patient is going from home to hospital, hospital to back, acute, outpatient setting. Every time there is a medication review. I know whenever my mother goes for an OPD appointment, there is always a medication review. And I participate in that. I always say, this is the last prescription, sir. I have put a, star there. Have reduced this on the phone because when I called you, now most of the consultation is happening on the video. So I would either tell it personally, or I will use the medication prescription and then write on the side itself and then send it to him saying, "Ki, this is the change." And I also started keeping her, all the lab investigation in an Excel sheet. I'm trying to help the doctor. I will share the Excel sheet to say, this is how our renal functions, lipid, and the blood sugar, HbA1c is behaving. So it kind of helps the doctor to the right decision. So we will have to assert ourselves into assisting the prescriber or the doctor in making the right decisions. And when you do play that role, I can tell you, you can be very proud of yourself. You will be saving the patient from harm or error every time when you're thinking for the patient. Coming to medication related harm is related to, we already discussed last week, also discussed this picture last week. So I am not going to get into this. Those who did not attend last week, you can always go back to our YouTube channel and catch up the recording there. So I'm not going to discuss about that. So idea is to limit the adverse drug events, and it should not result in any harm. Very rarely, some of them are not totally preventable because there are inherent risk of the medication, but then majority of them are preventable, and that's what we are trying to prevent, correct? So now, why consider medication safety during medication reconciliation? Because I told you I will tell you the burden. Now it's very important to look at all this percentage. Okay, now unfortunately, this is a global percentage after the research that they have put here. So it is good to know. 14 to 98 percentage of community dwelling older persons, 27 to 57 percentage of residential aged. So older patients, they tend to have very high medication discrepancy. It may be because of the age, they cannot remember, there is nobody to oversee. So it is very important that are we also paying attention when our elderly patients are getting discharged? Are you using the right methodologies to confirm that patient, the family, they have understood what they need to do? Now, coming to hospital admission. Hospital admission, they are talking about 3 to 97 percentage of adult patient, 20 to 72 percentage of pediatric patients had at least one medication discrepancy at the time of admission. Can you imagine the range? 97 percentage, 72 percentage. So I am very sure that there is a problem with BPMH and medication reconciliation, correct? That's why these figures are coming out. The next one, transfer within hospital. 2 percentage of patients had at least sorry, one unintentional medication discrepancy at transfer between units. So now this transition is a very, very important time for all of us. Spending time to understand the medication review and reconciliation is very important. Coming to discharge, 25 to 80% of patients had at least one medication discrepancy. We're talking about discrepancies. Now that is a pretty high burden. So it makes all the sense that we should be focusing on the medication reconciliation. Now let's talk about the medication related harm during transitions of care. What would that be? So it is the most common ones are omission post discharge. Now there is also a story there. Man was changed from warfarin to rivaroxaban, that is both are anticoagulants, to reduce the risk of stroke in patients with atrial fibrillation. We know that they are put on anticoagulants. This was started in the hospital. The discharge prescription was transcribed onto community prescribing system. This is online, but the anticoagulant was mistakenly omitted. 2 months later, the man suffered a stroke and subsequently died. So many a times we may not come to know that what did we omit, what did we commission, and what harm was had happened to the patient, because many times the patients are not from your catchment area. They get discharged, they go somewhere far. When something like this happen, they may not even reach your hospital for you to know there was a medication discrepancy. So this can happen at the time of discharge. Then non-adherence. Patient was admitted to hospital and his dose of methadone was confirmed. National treatment center and with the patient. On receiving his dose, the patient developed extreme opioid toxicity requiring reversal. So this patient was already on methadone. He had come to hospital, so his paper showed that he is on methadone. So they prescribed it back to him. It's a psychotic drug. So when he was given that, he went into opioid toxicity. Now, while deep diving, while doing a root cause analysis, they figured out that this patient was not taking methadone at his home. He was rather selling it for money because this is opioid. So there are many people to buy opioid. So he got a prescription, but he did not eat himself. He gave to someone. This was not caught by the healthcare provider during the history, because someone needs to ask the patient, have you been taking your methadone regularly? Because I will have to prescribe. So that dialogue need to happen. So the problem was with the patient, non-adherence. Then the harm happened. Lack of integrated care for physical and mental health. Now, 75-year-old resident of a nursing home admitted to hospital with lithium toxicity due to deteriorating renal function. The physician discontinued the lithium because that is recommended, and then patient had severe manic episode. Because when patient had severe manic episode, he restarted the lithium, as the reason for ceasing had not been communicated across the healthcare. Because the doctor who restarted, he did not know that the patient was admitted because of lithium toxicity, because renal functions were deteriorating. So he will have to look at the lithium dose. He did not know about renal impairment, so he reordered the lithium when patient had a manic episode. Then the patient again had lithium toxicity. So then it took a longer time for the patient to stabilize, because this is a catch 99 situation. You have to give lithium because of manic episodes, so you have to adjust the medication. So it can happen in many other conditions as well. Now, discharge prescribing error and delay in identifying medication related harm. Now, this is a very classical example, where you are entering a medication into a system and by mistake you selected something else. So, maybe this story is not from India, so the medication may not sound very familiar. So, the doctor was supposed to order Lance. It's a proton pump inhibitor, lansoprazole, all our omeprazole, ramiprazole, like that. So it was a discharge medication, but into the system, he by mistake ordered olanzapine. Olanzapine is antipsychotic, and he prescribed 30 milligram because Lance was 30 milligrams. So he ordered this, which is actually triple the usual dose. So 10 milligram above the maximum dose even. So pretty serious error happened, and the patient became unwell. The patient does not know. Patient thinks this is my prescribed medication, and patient started to deteriorate, and the pharmacist caught the error. And then the patient took more than 10 days to recover. So these kind of things, there are many stories in our hospitals as well. Now, this many of you might be knowing the Swiss cheese model, where the error reaches the patient when all these, loopholes, these holes all get aligned. So you can see there is a deflection happening here. So potential offenses which are possible. So let's look at this, discrepancy in discharge medication. Olanzapine prescribed instead of lansoprazole, right? So the first hole is there. When the first error happened, communication collaboration between healthcare professionals. That was the problem. The wrong entry happened. Then the second one, patient received the medication. The health records was not reviewed by at the time of dispensing. The pharmacist, they don't look at the diagnosis, they don't look at what medicine is being filled. So that error continued to happen. Error went unnoticed even after the patient deteriorated, because nobody noticed it, till the time patient was admitted to the hospital. So medication review was not happening when the patient was getting unwell. And again, the patient continued. And there, what is happening when the patient is becoming unwell, when they are telling a doctor, probably the medication reconciliation review was not happening to catch the error. What is the medicine that you are taking? Show me. And what is the prescription? And what is the diagnosis of the patient? When you marry all this, then you will come to know the wrong medicine has been prescribed. Okay. So finally, the pharmacist is the one that who identified at the time of medication reconciliation. So further harm was deflected. So this is a very classical Swiss cheese model, a very good, example. And those who are taking care of RCAs and quality, very good example to look at. Now, what is the economic impact of this entire thing? $42 million. How does this happen? Because there is increased need of healthcare resources in treating patients who are suffering medication error or medication harm. And it's a good thing for all the nurses to remember. Every time I do a training, I always ask them, when patient has any kind of unanticipated, injury, maybe it is a pressure injury, a fall, medication error, whatever it is, are nurses expected to invest more time? Answer is always yes. So every time the nurses will say, "Ma'am, prevention is better than cure." Very nice tagline. But are we always trying to prevent? Are we doing the right things? Now, when a discrepancy happens, we spend a lot of time trying to resolve that discrepancy. We know that any nursing leader sitting here, you know that when one thing goes wrong, next day your 4 5 hours is just simply wasted trying to investigate what happened, because you have to answer to someone. So you spend a lot of time. That is also money. Then, of course, if the patient goes to the court and gives a complaint or go to the police or whatever, there is resources that you have to allocate for legal proceedings and or claims. There are cases where you settle outside the court. Even there, the hospital has to spend money. So this is the kind of burden, 42 million. Now 15 percentage. Now what is the 15 percentage? Total hospital activity expenditure, 15 percentage of the total hospital activity and expenditure is actually going towards managing adverse events in OECD countries. We fall into that OECD countries, not your Western advanced countries. So it is very important to know that money wise also we are losing when we are not taking care of these safe practices. Then of course for all this there is limitation of evidence based. Most studies, they quantify medication discrepancies, but there is less evidence available in low and middle income country. And every time I say that if you look for any evidence in India, you will not find, because we don't have research to say that in India how much million it is going to be. This 42 million is in developed countries. We don't know what's happening in our. So we really don't know how much is the harm that is happening in transitions of care. So I also start thinking that there are so many nurses who are doing research and masters, and the people are doing PhDs. Why don't we get into these kind of topics? Can do a lot for our country and for our patients. So these are limitations which are there documented. So maybe we should take a heed of these information and see that can we come up with something? Can we study what is happening in our system? So what has been done to improve medication safety in transitions of care as per this document? So first of all, I already told, in the entire healthcare, the only constant factor is the patient. Whether he goes from ward to ICU, it's the same patient. Nurses will change, doctors will change, everybody will change. So, education as a solution to prevent errors. Now, the story of Uganda, what they have done there is they started educating school children on health literacy. So, health literacy led to a 60-year-old Ugandan woman to refill the prescription, and her grandson could identify there was a discrepancy. How did that grandson identify? Because he has been trained in his school. Now we know in India, we do not train our young generation in BLS, because in advanced, our other countries, Western countries, all school children, they are trained in BLS. They are also trained in health literacy to understand what are the communicable diseases, what is the burden, how to take care of the medicines, what all to be checked. So this is in Uganda, this is not in US. The second case study is improving knowledge and reducing misconceptions in a school-based intervention. Now, this is also in Ecuador. Now, these countries are not like US, but I couldn't find any examples of India in this document because it is not there. We don't have much to claim about, right? So, what do? We have to engage with patients, families, and caregivers. We have to have informed patients and patient tools, health literacy, as I mentioned, educate, not when they reach the hospital, maybe educate them much earlier to talk about the risk of health, what are good health habits, what do you do when you start medication, what should you stop, what should you continue. Maybe these are the things that you would like to start educating. So when I do any training for lay people, I do get chance to train people in sometimes in first aid, CPR. So there, whatever that I can discuss, I do talk about managing chronic diseases and what they should do with the medication. Provide specific medication information because it's very important. Many of the medications, especially the elderly people who are taking, they have very profound effect on the body. So they are maintaining their health based on all these medications, right? So they have to know what they are taking and what they should be taking care of, you know. Information at the time of discharge is very important. Medication reconciliation, I think we talked enough, and health workforce and skill mix consideration for medication reconciliation. Now, this is very important. Medication reconciliation is not the sole responsibility of a doctor or sole responsibility of a nurse or a pharmacist. There are models where pharmacists are playing a greater role, because I know that many of the JCI prepare or prepared hospitals, they do have a medication oversight process. That means when the prescriptions are given to patients, the pharmacologist will have an oversight. Is this medicine okay for this patient? Is this dose okay for this patient, right? So, but all of us cannot afford to have that kind of a medication oversight. But a smart nurse can always be a oversight for patients. So let me show you one site where you can find some tools if you are interested. This is from HRQ. Let me see if I can show you that. Yes. So if you come here, there is a complete HRQ Health Literacy Universal Precaution Toolkit. There are many things which are available. So if you are interested, please go ahead. All these presentations, PDF, you can find many things that you would like to learn about. So you can go there and check. So please go ahead, educate yourself, because this 90 minutes is not enough to talk everything about that can be done around medication safety. Now you have WHO's patient safety curriculum guide. So that is also one place where you can deep dive and actually figure out how training can be given to students. Now you have another resource here which I'm showing, medication at transitions and clinical handouts, called Match Toolkit. I really liked the word Match Toolkit. And those of you sitting here, you are serious about medication reconciliation, you want to improve medication safety in your hospital, maybe you would like to go and look at this one. We don't have to scratch our head and think what I need to do to improve safety. There is enough of evidence available out there. There are enough tools which have been checked and people are aware that this works. So you can look at that, you can modify them, you can use them for your own settings. So this is very important. So I have shared these two. There is another organization that you can look at, is IHI, Institute of Hospital Improvement, based out of US. So that is also one place. So improvement in information quality and availability across transition, because one need to improve the information that is available for the healthcare provider. So how do you do that? Single source of information. So ask to the patient and you take one more, maybe electronic medical record or a prescription. You add that. You takes information. Don't talk to 4 or 5 people. Maybe the son has just landed from another country and he may not even know what medication his father or mother is taking. Take from the reliable source. Patient is the best source. If not, someone who is staying with the patient is the next best source. Then go to the medical record. You can use forms and checklists. So when I was in Fortis, what we did not design a very complicated one. We actually designed one landscape kind of a checklist, in which we, on the side, we said medications taken at home. So we made all the list there. Then at the time of admission, then we put there what all medications the doctors have written. And my specialty nurses, they used to highlight the medications which are not prescribed to the patient. And they will write also that this is now held for some time or it is discontinued because of whatever. They used to make the notes. And then at the time of discharge, the same paper was used to see that whether any of the medication the patient came from home, have we missed to prescribe when the patient is going home. And I can tell you from our own experience that we were able to catch many. They were all near misses. If the paper, that reconciliation sheet was not there, the things could have gone wrong. It was a very basic, paper based reconciliation form that we created, and it was entirely done by my specialty nurses, and doctors were very happy. Initially they were saying, oh, why we are having this one. I took it away from the assigned nurses, because specialty nurses, they each one had maybe 20, 24 patients, so they were only expected to oversee the care of the patient, go for rounds, guide the assigned nurses. So that model worked very well. If any one of you is interested to know how that model works, you have my contact. You can send me message. I can share with you how did that model work. Then discharge, post-discharge interventions. So now the pre-discharge education is very, very, very important. And I know it is a very weak sport. I do a lot of training for various programs in various hospitals. When I get them to audit this discharge teaching, we find a gap. And I will tell you what is the reason that there is a gap. It's not because the nurses are not educating the patient or the family. Most of the time they are doing, but there is a gap that is coming. We'll come to that in a minute. This is the gap. Teach back is the problem. What we do is we tell everything to the patient. Sir, you are going home. You are supposed to take this medication this morning, evening, night. We go through the entire list and we say at home, you take care of this, you do this with your food, you do so many things we are telling the patient and the family. And in their head, what are they thinking? Oh my God, how do I pay the bill? Now the bill is so much. How am I going to pay the bill? So when we get home, okay, who is going to look after my father? Where is he going to stay? His bedroom is upstairs. Will he be able to climb? So there are many things which is going through their head. They'll say yes, yes. Half the things they will understand. All the audits that we did and during my training on Teach Back, they all had gap. So, discharge planning, medication reconciliation, medication review, the tools, how do you transfer this information? Can you have information booklets in their language, local language, that they can take home? Or can you have maybe a small note where you keep all the medications on one side and ask the patient to write down in their own language how they are supposed to take the medication? I know there are a lot of doctors who actually, make gola in the prescription, round, round. They don't write BD, TID. They actually make that figures there so that they will know I have to take 3 times a day. And on top of that, you can write the timings. So there are many ways that we can ensure that we are giving a complete discharge teaching. And I'm very sure in this, the role of doctor in our hospitals, at least where I worked, it was minimal. Doctors will say, I have written all the medication, sister will explain to you. That's the standard answer. Now, sister in her all business, she will go and explain everything, but half the things are already gone. It's very important to ask the patient to teach you back, or the patient to teach you back. Just tell, sir, I explained many things. Now, could you please teach me back so that we can be on the same page? Maybe you have to ask different ways to confirm that they understood what you are trying to teach. Now, this is a nice list. This is not from the WHO document. So I would like you to kind of say yes or no in your own head. Can you explain some of the changes we decided on today during your visit? I want to make sure that I was clear that you have the best outcome. So you need to say that are they the correct dialogue for proper medication reconciliation? So maybe can I see it is yes or no in the chat box very quickly? A few answers. A few answers. Can someone write yes or no? The first sentence, is it a good sentence used to confirm the patient has understood? Can I have yes or no? Okay, we already started getting yes, so very good. So that is an yes. So next question, do you know how to use this device? Is that a yes or no? Okay, again, I'm getting lot of yes, but please learn today. Remember, closed-ended questions are an patient will say yes. How do you know how to use this device? He'll say yes. That is no guarantee that he really knows. You have to ask the patient to show to you that they can use it. So this is what I would like you to take home today. Don't ask the patient whether you know. Can you show how to use it? Exactly. Can you show me how to use it? Do you have any question? There is something black coming up again. Sorry. Okay. Do you have any questions? What do you think? Yes or no? Those who answered no, very good. I want to make sure we are on the same page. Can you explain to me what your next steps are when you get home? Is that a yes or no? When I put on the chat box, unfortunately, somebody's telling that you are having a shadow, so I'm not putting on the chat box. So that's a yes. Do you understand? Well, even to your student, I also tend to ask, do you understand? Did you understand? And very easily everybody will say yes. But in my class, it's very difficult to get a teach back from everyone, no? But it is a no. Unless you get them to explain, it is actually a no. In your own words, just to be safe, what are some possible side effects of this medication? That will be definitely a yes. Are we clear on next treatment steps? Very easily we ask, no? Even the doctors will ask, are we good with this? Did you understand? That's a big no. So I can be sure we have the same understanding. What else can you do to help your condition? There are many different ways you can verify that the patient understood or not. As a safety check, can you show me how could you use the inhaler at home? It's a dialogue. Yes. Do you know how to take this medication? By this time, all of you know what is the answer. It's a no. So maybe you have given a set of instruction to the patient. Maybe you would say, okay, sir, thank you for your time. You listened so patiently. Would you be kind enough to repeat it back to me so that we are on the same page and we will ensure that you don't forget? Maybe you can ask them to make notes. Do you have a diary? Would you like to take the notes while I explain to you how to take the medications or what to do at home and what not to do? We have to have a very lively, interactive discharge teaching. And I can very well guarantee that's a weak point in our system. And that is something nurses can definitely improve. That is my call out to you. You can't boil the ocean, but we can definitely make small changes in our own setup. And all the students sitting out there, you can learn today this is how I can make myself safer around my patients. So, what needs to be done? There has to be leadership commitment and planning. So, all the leaders sitting out here, now going out from here with added accountability and responsibility to improve your medication reconciliation and start with improvement programs. And do let us know in case you have done an improvement program and you saw results, make it a compulsion to share that story with others so others can learn from it. Don't keep it to yourself because it is for our patients. Always partner with patients, families, and caregivers. Very important. And do not forget the medication reconciliation and information quality available at all transitions. So every transition, we make sure the quality of information that we are carrying forward is correct, they are reconciled, they are accurate, and the patient and family has been involved at every transition. And then most importantly, building the capacity of healthcare professionals, doctors, nurses, pharmacists, and Signe Healthcare and me, we are doing a small effort in educating as many nurses and students as we can. And this video is going to be available on the YouTube. I hope more and more people will, learn these domains a little bit deeply by sitting and watching this YouTube. And a shout out to the leaders that you can make this into a CNE, you can show in your auditorium or classroom, and Maybe you can create a small quiz after this so that your staff or students, they are learning from what is being discussed here. So that's the way we can percolate that information to more and more nurses and students. Monitoring and measurement, very important. Are you auditing if the reconciliation is happening, whether it is happening correctly? Is the BPMH is being taken correctly? That can, there is no list that is sacrosanct or written in stone say that one hospital can only have these many quality indicators. Why can't you make a BPMH a quality indicator at that time of admission? Best, quality medical history is being, medication history is being taken and documented. Maybe that's where you can start. Then there are some other quality indicators. The WHO is suggesting percentage of patients with at least one outstanding unintentional discrepancy. So you can start from the time of admission to find out whether there is unintentional discrepancies happening. Usually the unintentional is the one that you would like to catch, because I don't think that intentional discrepancies would happen. Most of the discrepancies would be unintentional. So the formula is also given there. So you can go back and look at this into the document, because document is easily available. In case anybody finds it difficult to find the document, just message me. I will share the document with you, no big deal. Percentage of patients receiving medication reconciliation, I just mentioned. You can change this in a small way to say at the time of admission. So BPMH, that you are going to start to monitor. Then you will broaden your horizon of monitoring. Now, this is a very good way of starting. I would really encourage all of you. It's a very small question that you are going to ask to a patient who is getting discharged, maybe. Did a member of staff explain the purpose of the medicine you were to take at home in a way that you could understand? Purpose. It is not how many times you have to take. Do you know the purpose? Why are you taking the medication? So the answer is yes, completely yes to some extent. No, I did not need an explanation. I had no medicines. So maybe you can start this as a quality improvement project. There are so many things that we can do. We don't have to do everything that you are hearing today. Maybe that is too much to digest. Maybe somewhere you can start. I personally feel this is a good place to start. BPMH is a good place to start. So patient centered measures. I am always a champion. Who will tell nurses are great? I always tell there are only two P's who will tell nurses are great: patients and physicians. Nurses cannot tell themselves that we are great. Let others tell that we are great. Measuring medication related harm arising in transitions of care. Now, very important, because all of you track medication error. Maybe you would, when you do a RCA, you need to figure out whether that happened at transition of care. So there you understand the definition of transition of care, then you will know that it happened at the time of transition. Now, the last bit, role of nurses, very important. This list is not from WHO. This list I have created myself from my own experience. But I will always refer to WHO's know, check, and ask. That is the mantra. Know, learn about patient's condition and medication. I always say if you don't know the medication, don't invest. Ask someone, learn about it. Always identify patients with two identifiers. It doesn't matter you have been looking after the patient for 2 months. Every time you give medication, identify them with two identifiers and always carry the medication orders to the bedside and match the information. Involve your patient. Very, very important that you involve patients and caregivers. Always do your three check. Always three check. I discussed about self three check for all medication. Never ever overlook a 2% check for high alert medication. Don't ever think, oh, I have given insulin so many times, so I'll just tell Didi to countersign. Don't take it casually, please. Because maybe for 1 year, 2 years, 3 years, 4 years, nothing goes wrong. Because I've heard of stories where say she's such a smart nurse. She never had made mistake. What happened today? Because many times we take shortcut, nothing happens. Then it gives us confidence that we can take shortcut and nothing will happen to the patient. That is how sometimes errors happen without intention. Always follow at least 5 rights. I know everybody knows about 10 rights. I would say start with following the 5 rights always. It's like a mantra. Never ever skip that. Always involve patients and caregivers. Participate in medication reconciliation. Can you lead medication reconciliation? Then it is even great if you can lead medication reconciliation. If you think the doctor is slow in catching up on the medication reconciliation, why don't you go ahead and lead? That's a nurse led quality improvement program. Include medications in handoff always. At the time of shift handover, always talk about medication. Do your own medication review and reconciliation always. I'm very sure that many times the assignments are, similar patients. We try to do that. So the patient that yesterday he was on that medication. You can ask, no, what happened to this medication? Oh, this was stopped. What happened? Is it better? Is there a reason? Try to understand why something is started and why something is stopped. Explain and educate patient all the time. Whenever you are giving medication, explain what you are giving and why you are giving the medication. It will all come handy. I always used to talk throughout my medication process. When I was a bedside nurse, I'll be talking to the patient. I'll be saying, okay, I'm here to give medication. So we have the chart, sir. You have got this, Lasix and digoxin. And yes, there is an aspirin for you to take at this time. So let me take out the medication, sir. So digoxin is 0.5 milligram. Right, the Lasix is 40 milligram. The aspirin is 1 tablet. Okay, I've got all this medication. So, sir, can you tell me what is this Lasix for? I taught you yesterday. So I have that dialogue all the time. So what happens in case I am telling to myself I'm doing the right thing? Patient is involved. So in case there is any discrepancy, he will tell you. So yesterday morning I had 4 medication. Today you are only giving 3. You will go back and check. It's an opportunity to either you'll say, okay, the fourth one, yesterday you got this medicine, but this was stopped yesterday because your blood pressure is already better, or the fever medicine is stopped because you are now not having any fever. You know the reason. Explain to the patient. It's very, very critical. Always use teach back. We talked about teach back. So, especially on discharge. So I have a suggestion to especially the leaders sitting there. If not all the patients can get into this discharge teaching and teach back, is there a way that you can develop few nurses who can take care of the discharge teaching? In Fortis, we also used to have discharge nurse. Primarily, they were created to make sure the patients are going home and the planning is done, everything is being done on time, and they go home. And we take pride that discharge time was reduced by 50%, 60%. So to the discharge nurse, it's responsibility also to educate apart from the specialty nurses. That was the best model that gave me fantastic results, because my specialty nurses will also give a post discharge call. So I'm going to show you a video where a special initiative by a hospital, not in India for sure, they are discussing. So this is an idea for all of you. You don't have to copy paste, maybe something similar, maybe remote. There are many different ways you can help a patient. So now after COVID, we learned that we can actually see a patient by video, check on them, how they are doing. Do they know how to care for their wound? There are many things that can be done by nurses itself, if they care enough. So let's just see this video quickly. Very short one, 2 minutes.
Moving that sharp experience from the hospital to the home is really what we're doing. Our coaches are there to support those patients as they transition home.
When my patients discharge from the hospital, I get to see them at home. Most people don't get to do that. I do.
That first 30 days home is imperative to healing and managing their disease. SHARP is there for them through this program.
I've had 4 strokes.
And the point is to empower that patient to manage their care in their own setting.
How are you doing with the blood pressure machine? Did you get that one?
Yes.
For someone to walk in their room and say to them, I'm going to help you get in charge of this, is very, very empowering.
Tell me again what this one is for.
I have no idea.
Medications are so complicated and medication regimens can be very complex. So there's just a lot of room for patients to become confused.
Pharmacists will call the patient at home and make sure their medications are correct.
I make sure that they were able to pick up their medicine. I make sure that they were able to understand what their medications are for. I also make sure that there's no issues with their medication once they're home, so that they're not experiencing any side effects.
This is one of the medications you will need for a while.
I'm a hospital pharmacist, but I really care about what happens when the patient goes home. My heart is really in being very proactive for our patients.
I never felt like this before in my life. And I don't know what I'd have done if you hadn't come along. I'd have been in bad shape by now.
Well, I enjoyed my visits with you all the time. At Sharp Healthcare, we care about our community. We care about our patients.
So, friends, so that is Health Coach, an initiative by one hospital to reach out to patients when they go home. So, they also involved pharmacists. So, think about it. The leader sitting here, think with a creative mind to say that since you came to this 90 minutes of session, are you going to do something different as an individual nurse, as a leader? And take this mantra home, know, check, and ask, know the medications that you are going to, administer to the patient. Never let it go. Don't give something that you are not aware. What is this medication? What is its action? What is its side effects? What am I supposed to tell the patient? Minimum you should gather this much, and without reading a lot from many books or anything, if you ask a doctor, you will get an answer. So I really hope that you all are in the pursuit of patient safety and you are going to do something in your individual capacity, and also leaders who are out there, you're going to do something in the process and the structure of ensuring medication safety, especially focusing on medication reconciliation, and very, very importantly, when we discharge patients home. So thank you everyone for being here. And I'm going to next week, that is 26th, and we are going to discuss about medication safety in polypharmacy. That's the fourth in the series, and then there will be a last one. Thank you, and stay safe and stay positive, and make a commitment of patient safety to yourself and to your patients. Thank you very much, and see you all on 26th of August. And I will stop the recording now.